Good morning, everybody. Thanks for coming for this seminar. And it is a great pleasure to me to introduce our today's speakers. Dr. Gillenwater, she's an associate professor at the Department of Head and Neck Surgery, University of Texas MD Anderson Cancer Center. Is one of the most important centers for cancer research, and she's also a professor at the Department of Bioengineering, Rice University, and at Baylor College of Medicine. Dr. Rebecca Richards-Carton, she's a professor and the chief of the Department of Bioengineering at Rice University. All those institutions are located at Houston, Texas. And Dr. Rebecca Richards-Carton got her PhD in medical physics at MIT. And besides all other individual research activities, they work together on the development and validation of optical imaging and spectroscopy technologies to detect oral cancer and oral premalignant lesions, and which is going to be the topic of the seminar, this joint seminar today. So I'm going to ask the audience to keep the questions after the talks, since we are going to record these talks. And thank you very much. It's very nice to have you here.
All right. It's an honor to be here. Thank you very much, Vandalie and Christina, for inviting us. We're very excited about being able to look at your wonderful lab and also to hopefully be able to establish some collaborations. I'm going to talk first. And as Christina mentioned, our research interest is in developing optical technologies to improve the detection and the diagnosis of epithelial. All right, watch out. Is that better? Okay. We're trying to develop optical technologies to improve the detection and diagnosis of epithelial malignancies. I deal with oral cancer. Rebecca's also done extensive work with cervical. And I will get going. And as I don't need to tell you all, but optical technologies are very exciting and have substantial benefits and potential for diagnosing epithelial malignancies, which account for over 80% of all the cancers. I've been working in the oral cavity, and Dr. Rebecca Richards-Carton has been working in the cervix for many years. We're also starting to branch out into working in the esophagus and the skin. I'll focus this talk predominantly on oral cancer because that's what we have the most experience with so far. It is a major problem. It's a major problem for global health. It's the 6th or 8th most common cancer, depending on which series you look at. It is predominantly a disease in developing countries. And if you can see on this map here, the ones that are in the dark have the highest incidence. And usually we think about it occurring predominantly in South Asia, as well as in Indonesia. But you can see Brazil is also highlighted here with the one of the highest incidents of oral cancer. The problem with the oral cancer is it causes not only causes death. There's a high mortality rate, but there's also severe morbidity associated with it and severe expense. Most patients present with very advanced lesions when the therapy is just not as good. It's very expensive, and it's debilitating. It causes horrible problems with speech, swallowing, as well as cosmesis. So we think that the best way to improve survival for this kind of cancer is to improve early detection. Now, the oral cavity is a great organ site to pick for early detection because it's very easy to examine. You don't need any special rooms. The patients don't even have to take their clothes off. All you need is a light source and illumination to be able to open their mouth. There's also a well-defined progression model. And what do I mean by that? Basically, most cancers in the oral cavity just pop up overnight. There is a progression from normal through various precancerous stages before you finally get the cancer. And the progression means that researchers have identified both clinical lesions that predate established cancers, as well as pathological progression. So you can start with a normal epithelium within the pathology, dysplasia, and then cancer before cancer arises. And sometimes the cancer doesn't know that it's supposed to go directly from here to here to here to here. It can, but the take-home message here is that identify these cases when they're in the earlier stages. We have an opportunity to intervene and either reverse those changes or stop them. And the other major take-home point is years. So that gives us a long window of opportunity where we could identify these patients and treat them when the disease is very curable. No one's going to die from a precancerous lesion. The other advantage of oral cancer is that we know many of the risk factors for the disease, so we can identify the people who are at risk that we should target screening efforts to. So in the United States, the major risk factors are smoking and tobacco chewing and alcohol. In other parts of the world, it's using betel nut or pan. And there's, of course, about a third of the patients we don't have an identifiable risk factor. And finally, there is this cohort who a clinically apparent premalignant lesion. So if you see one of these, then you know that this patient is at higher risk. And the most common precancerous lesion is something we call leukoplakia, which is a fancy medical term which means white spot. So when you have these white spots, you're at an increased risk of having oral cancer, developing oral cancer. There's also something called erythroplakia, which means red spot. If you have red spot, that you're at an incredibly, very high rate of developing oral cancer. It's 90% or greater. Despite all these reasons why it's easy to diagnose oral cancer, the patients still present with very late disease. Why is this? Even in the United States, where we're supposed to have a good medical system, most patients are still presenting with very advanced disease. And I think the reason is that it still requires somebody to examine these patients' mouths. And a lot of times patients don't have access to medical care, they don't come to the doctor, or when they do, the healthcare worker can't recognize that this is a precancerous or a cancerous lesion. And that's because many of these lesions look much like the much more common benign lesions. And the only way to really identify a cancer at this time is for the examiner to be able to recognize it and then to do a biopsy and to look at it under the microscope to confirm that it is cancer or precancer. We are trying over the years to make better ways to diagnose it. So currently the standard is just clinical examination using white light and fingers, and then an invasive biopsy that you look at under the microscope after you stain the tissue. For decades, we've had something called vital staining, which usually is toluene blue, and the idea is you place the blue dye and it's taken up more by dysplastic or cancerous lesions than by normal lesions. And this has been around for decades, and hardly anybody uses it. And probably the reason for that is that it's very operator dependent. I mean, it only really works for people who are good at diagnosing anyway. And it's, although it's very sensitive, it's not specific. Other techniques that have been around are a brush biopsy, where basically you do scrape and do cytology. And there have been some newer agents that have been coming out now. There's something called Visalite, where you use acetic acid and then a blue chemoluminescent light to visualize the abnormalities. And then there's a new fluorescent imaging device called the Velscope. What we're going to talk about today is optical imaging, because that's what we think has the best potential for improving diagnosis. So once again, our goal is to develop technologies that can improve the ability to diagnose and detect these oral lesions before they develop into those horrible pictures I already showed you. We've been working on several concepts, but first I'm going to be talking about wide field imaging, and the object of doing wide field to scan large areas of the mucosa of the epithelium and identify areas of abnormality. And this is important because you want to be able to pick up lesions or to help people identify lesions that are suspicious. After that, we're going to be talking about point spectroscopy, because once you identify a lesion, then you need a way to determine whether or not this lesion is suspicious or not suspicious. And so we tend to think that the wide field imaging is better for detection, so you need it needs to be very sensitive, whereas the point evaluations, we want to be very specific, because we want them to be able to tell us whether or not something that we picked up already is really a danger to the patient. So I'll start with the fluorescence imaging and spectroscopy. And the concept behind this, and I'm sure you all know it's preaching to the choir, is that you shine light at different wavelengths. The light interacts with the tissue. Some of the light is going to be penetrating through the epithelium and down into the stroma, and it will be interacting with the different molecules. So we're going to have scattering reactions. It will hit some absorbent chromophores, so we'll have absorption. And then some of it's going to hit fluorophores, which will cause the re-emittance of fluorescence, which can be detected either by a computer system or by an eye or a camera. And these interactions vary depending on different states of the tissue. So it'll vary depending on how many chromophores or how many fluorophores and how many absorbers you have in the tissue, as well as other things about the architecture of the tissue. So you can use this information to ascertain different properties of the tissue that you're examining. For macroscopic imaging, as I mentioned, we're going to be looking at several centimeters of tissue at the same time. And Dr. Kortum's group designed a system we call the MDM, which is the multispectral digital microscope. And with this device, which was predominantly put together and designed by Darren Robler, we are able to image the tissue with reflectance. So to use white light, which is what I, as a clinician, am used to looking at. So this is very important for me to be able to look at something with something I'm familiar. But we can also look at different wavelengths. We can look at polarized or orthogonal images and fluorescence images. And so here's a picture of the MDM that was designed. Now this concept is not new. Fluorescence imaging has been used already. There was something called the LIFE system developed in British Columbia that has been used for 10, 15 years, predominantly to look at lesions in the bronchus. And as I mentioned, there's also a device developed by the British Cancer Center called the Velscope, which is being marketed to the dentist in the United States. But both these devices have certain limitations. They use only a certain bandwidth, and we think we can improve on their ability to diagnose and detect lesions. So we started out initially in ex vivo specimens. So we took tissue that had been resected in patients that had cancer. And then we looked at various different wavelengths to see where we could see the edges of the abnormality, the edges of the cancer. And we did several cases like this, and what we found was that the best wavelength combinations for us to be able to detect the borders between the abnormal or the dysplastic tissue and the normal mucosa was at 440 and 530. And we did this initially to help get an idea of what wavelengths we should use in our system. Then Darren designed the MDM system, and this has a variety of different wavelengths. So again, we could help determine in vivo which would be the best wavelength combinations. We wanted to look at reflectance as well as polarized light and fluorescence. And these are some of the very initial images. These might even be Christina. This is Christina. I forgot that. This is the a normal oral lip, and you can see the different combinations. This is white light, this is the polarized or orthogonal light, and then you have 420 reflectance, 530 reflectance, 600 reflectance, and 365 fluorescence. And what you can see is that you have different abilities to visualize the vasculature depending upon the wavelength that we're using. And because this is a microscope, it's a clinical microscope that we normally use for evaluating patients' ears, looking for ear infections, or it's also a dental microscope that you can see we have very high resolution. And then we took the instrument to the clinic and evaluated its ability to improve a clinician's, to improve my ability to pick up lesions. And this is in particular as a patient I had been following for several years because he had a history of carcinoma in situ. That's dysplasia, which is almost cancer. It's the next step before it becomes cancer. And I saw him on exam, and I didn't see anything on white light. And then we used the fluorescence imaging, and you can see you can start to pick up a lesion right here, which was not visible to my eye on white light. And here and here. We did a biopsy of this area, and it showed carcinoma in situ. So I think this was a good demonstration, at least to me, that this has a good potential for increasing the clinician's ability to detect new lesions. The other aspects we wanted to evaluate was whether it improved our ability to choose the best site to do a biopsy. And here's another patient who has a leukoplakic lesion, a white spot. And normally, as a clinician, we tend to go right for this white spot. In other words, we're going to do a biopsy right here because that looks the worst under white light. But what you can see on the fluorescence imaging is actually this area has a loss of fluorescence, which would be a better site to do a biopsy on. Because as I hope I'll demonstrate with some further pictures, it's this loss of fluorescence that shows the abnormal area better than a white spot on clinical examination. The other idea we wanted to test was whether or not multispectral imaging would improve our ability to tell how far out the lesion extends. And this is a very important point for a surgeon. If you take somebody to the operating room and you're going to do a resection and you're going to cause all the trauma, you want to make sure you got the whole thing. Okay? You don't want to find out that you left some of it in the patient. So it's very important for us to be able to determine where are the edges. And this is the same not only for surgery, but for any other treatment modality, pretty much. If you're doing radiation therapy, you want to be able to get the full extent of the tumor. If you're doing photodynamic therapy, you want to get the full extent of the disease. So these are the things that we're still looking at to see if multispectral imaging can improve our ability to take care of these patients. And these are just some pictures that I'm going to use as examples of what we've been able to see. Again, here, this is the white light. Here is the polarized light, and you can see you get areas of increased redness or increased vascularity associated with these lesions that you are not quite as obvious in the white light. And again, with the fluorescence, you're beginning to pick up better contrast. And then the fluorescence, it becomes really obvious where these abnormal spots are. Here's again another patient. This is the white light image. This is a patient who had this area here on the oral tongue, which is not that obvious to a clinician under white light. She had a long history. She's had biopsies in the past that showed severe dysplasia. And we actually biopsied this lesion, and it showed severe dysplasia, which is, again, almost a cancer, as well as significant inflammation. And I think you can see as you go through that the polarized light shows you better contrast. And then on the reflectance and images, and this is a fluorescent images where you see a bright ring of porphyrin around the edge. We don't know exactly what's causing this. It might be bacterial contamination at the edges of the lesion. Again, this is another patient who had severe dysplasia of the buccal mucosa or the cheek. And again, you see these areas of loss of fluorescence. And if you watch those spots, you see that there's much better contrast, and there's larger area of abnormality that's picked up on the fluorescence images. So those are some of our results. We're currently analyzing those, trying to come up with a parameter to show which of these modalities give us the best discrimination between normal and abnormal, and how we can use these in the clinic to help the not only the physicians but other healthcare workers identify these lesions. We're also looking at some new directions in this wide field imaging. One is to detect skin cancer, and that's something we're excited about, possible collaborations here in Brazil on skin cancer. And I'll also just mention briefly some other ideas. Now, skin cancer is a major problem. It's a major problem in the United States as well as here in Brazil. Again, it's really easy to treat it if you catch it early. If you wait until it's very extensive, then it's just horrible. This is a case we did actually last week. This is a patient who's had a long history of basal cell carcinomas, and this is a white light image, and it's rather difficult to see the area. Now, this is magnified with the microscope, guys. Let me tell you, in the clinic, when you don't have that microscope, it's even harder to see these lesions. But here's a picture of the polarized light, and you're beginning to pick up the increased vascularity. See these spots? And then we're going through the different wavelengths. This is 575 or polarized. This is 530, the reflectance, but polarized. And you're beginning to, again, to pick up some areas here that look suspicious. This is at 430 with the polarization, and you really see the scars from his previous excisions. And now we're getting into the fluorescence. This is at 365, and I think you can see the larger area of the loss of fluorescence. 380. This is 405 and 450. And I think these are we're very excited about these results because it really shows some of the very nice contrast between where he had his basal cell carcinoma and the surrounding relatively normal skin. This is a drawing. I had the resident come in who hadn't seen the fluorescence images and use the white light and draw the areas where she felt the abnormality was. And you can see on the white light exam, she would have missed these areas of abnormality. So we're really excited about the skin cancer, and this is just starting, but the results are looking very promising. We're also working on developing a portable screening system because the MDM, which shows us some very good results, is fine for a big research institute, but that's not going to work in the community. It's much too big and complicated. This is a device that was designed by Mohammed, who is right here, being the guinea pig for me to practice on him. Basically, it uses, it's portable. It's on a headlight, so you can walk around with it. It's battery-powered LED, and it connects to a laptop for data acquisition. This system right now is in Mumbai, India, and we were looking for features that it could be used without a reliable source of electricity, because sometimes they lose electricity there, and we wanted something that was very robust and relatively inexpensive and easy to replace the parts. So it's currently in India right now being evaluated, and here are some pictures that are taken. This is a patient here who had a biopsy-proven squamous carcinoma, and on the white light, you really couldn't see much of anything. So here's the white light here, and you really couldn't see much of anything. But on the fluorescence, you see the small area of decreased fluorescence, and this is the orthogonal. You can't really see it as well, or I can't see it as well. But this patient had residual severe dysplasia. And these are some of the pictures from India that Mohammed has taken. Again, you see this leukoplakia here, and loss of fluorescence here. And then, again, leukoplakia. And I don't know if you all can see it down here in the corner, but there's a large area of loss of fluorescence. So we're still trying to get the trial matured so we can get some information, but we're pretty excited about this too. One of the other issues that we're looking at is how to correlate the pathology to really tell, what's the difference between an area that has loss of fluorescence or area that has increased vasculature from the polarized light and the pathology. And it's something that's been very difficult for us to figure out, is how do you exactly correlate the images with the pathology. And what happens is you take the specimen and then you cut it into pieces and then you look at it under the microscope. And what we've tried to do is to actually put ink on the specimen where we see these different features that we have identified using the MDM, and then to go back and reconstruct with these slices an image or a map, a pathology map. And here's just a high power, so you can see, this is an area that we had marked with red, and that was where the cancer was. And so the idea is hopefully we'll be able to come up with a map so we can correlate that and reproduce it and compare it to the image. But that's been a real challenge, trying to compare the pathology exactly with the image. And here's a result that Rebecca has worked out with the cervix, again having the same difficulty trying to make the map, but they've come much further along. And you can see here the lesion, and they've overlaid the map on top of the lesion so we can compare the image to the pathology. And one of the other issues that we're looking at is to a combination of point diagnosis with wide field imaging using hyperspectral imaging, and I know you all are working on that too. But it's basically to take this image and then to be able to get certain points from it to analyze individual spectra. And I'm going to move now into point probe spectroscopy, or evaluating a small area to see if we can determine whether an individual spot is precancerous or cancerous. And we designed a system we call the FAST-EM4, which basically it's a research grade spectroscopy system. It is designed to identify or diagnose oral precancer. It's a fiber optic system. It collects an entire emission matrix, EEM, from the tissue. There's 12 excitation wavelengths for fluorescence, as well as broadband reflectance, and there's 4 different channels, so it measures a total of 52 spectra from each site. And one of the exciting things about this is the probe. The probe is unique. It's got a ball lens in it, and the reason for that is because we had done some initial studies that showed that when you have you evaluate the fluorescence, the fluorescence from the epithelium increases as you move from normal to abnormal. So in the epithelial layer, the normal image has less fluorescence coming from the epithelium than the abnormal image, which I know sounds backwards from what we looked at. But the stromal layer has less fluorescence. And Rebecca will go over some of the newer data we have indicating why this is happening. But we see this consistently both in the cervix and in the oral areas, that the stromal fluorescence contribution decreases, whereas the epithelial fluorescence contribution increases. And so you're sort of getting competing signals from the area, from the stroma and the epithelium. So this brought to our mind a question is, well, maybe we can improve our results if we separate the signals from the epithelium and from the stroma. So that's why we have this wonderful new probe. It uses a ball lens to help direct the illumination and illumination signal so that it is targeted on a shallow layer. So we have a depth-sensitive probe, so we can illuminate and detect signal from the epithelium, and then there's also the deep channels that don't go through this ball that we can use to interrogate the stromal layer. And this is just an in vitro evaluation of the probe with a thin fluorescent target, which showed that it did indeed allow us to pick up signal from specific layers. So there's 4 channels. There's one that we call the shallow channel, one that we call the medium channel, and then the 2 deep channels, which are used to target the stromal area. So far, we've done 124 patients and volunteers, a total of 424 sites. And we've just gone through all the analysis of this cohort. What we found was that the data separated best if you separated the normal through and the inflammatory and the benign lesions and the mild dysplasia, and those were our normal group, and the moderate dysplasia to cancer were the abnormal group. And I was very happy that the data settled this way, because this is exactly the way, as a clinician, I'm going to view the patient. If I get a diagnosis of mild dysplasia, I say, oh, don't worry about it, it's probably reactive, we'll just watch it. Whereas if you have moderate dysplasia or higher, then we usually are talking about intervention anyway. The other interesting point we found with the data was that we had to separate the cases that were from different areas within the oral cavity. The mouth, unlike the cervix, has very different anatomic areas, and you can probably realize that if you look in your mouth or use your tongue to feel around. But there's keratinized epithelium in the palate and in the gingiva, and this is to protect it because that's the ones that's exposed to all the trauma from the chewing. So you have a real thick, tough layer around your teeth as well as on your palate. You guys some of you all are dentists, so you know that already, sorry. Whereas the buccal mucosa, the cheek mucosa, and the floor mouth, and the side of the tongue is much softer. It doesn't have the thick keratin layer. And what we found out is there's very different optical properties from these 2 types of tissue. And so what we had to do is separate them in order to generate the algorithms. And these are some of our initial results from this analysis, and you can see that we did get very nice separation of the normal mucosa spectra from the dysplasia, which looks a lot closer to the normal, and then you have moderate to severe dysplasia and then cancer. This is just an average of the fluorescence spectra at 390 excitation. And again, you get good separation with the reflectance data. You see, again, the normal here, the mild dysplasia, and then the moderate and severe dysplasia and your cancer, which all separate very nicely. And to cut to the chase, this is the results from algorithm performance, where we looked at a ROC curve, receiver operated curve, which shows us a good indication of how sensitive and specific our algorithms were. And these are scatter plots of the posterior probability, which also show some very good separation. This was our initial test set, excuse me, yeah, this is our initial training set. So we divided the data into 2 separate groups, and this is our initial training set, and this is our test set, and we still get very good discrimination between the abnormal, defined as moderate dysplasia and worse, and the normal, which is everything that isn't moderate dysplasia or cancer, so absolutely normal or benign lesions. So we were very excited about these results. And the conclusions that we got here, as I mentioned already, that you get very different data when you evaluate the keratinized areas of the mouth versus the non-keratinized. So we've come up with very nice algorithms for the non-keratinized. We still need to get a little bit more data before we have enough patients for the keratinized epithelium. So that's another goal that we need to work on. We also found that the shallow channel gave us much better information and better discrimination between this normal and the abnormal than the deeper channels. And I think Rebecca's going to give a little more data in the second talk that helps explain why we think this happens. And again, we found that the mild dysplasia classifies better with the normal group than the abnormal, which is good as a clinician. I like that. And we've got very good sensitivity and specificity. So where are we going with the spectroscopy? Again, we want to develop a more portable device using fewer wavelengths. The FAST-EM4 is great. It's a wonderful research grade. It gives us a whole lot of information. But it's not real practical for taking out in the community. So we need to get a portable device. And we were very excited to see your portable device. We're going to use LED light sources, and again, we want to use a ball lens probe that we can target to the superficial layer. We also want to do an evaluation in a community setting where we evaluate not only the spectroscopy, but also multispectral imaging, as well as some of the other modalities that are currently used, including the standard white light examination and also a brush biopsy that where you brush the tissue off and look at the exfoliated cells under cytology. So we have that planned. We also want to look at patients who we know are high risk, the patients with that leukoplakia, the white spots, or the erythroplakia, and see if we can do a prognosis. In other words, to identify which of these patients are going to progress to cancer. Because not all of them will. Only somewhere between 17% and 30% of them will eventually get a cancer over the next few years. And it's really important for me to spend my time on the patients who are really going to get the cancer rather than on everybody. And so we'd like to be able to figure out whether or not we can determine that prognosis with some of these imaging modalities. So I'd like to acknowledge all the people who did the work. It's a huge group that we're working with. A lot of people at MD Anderson, including the pathologist. Christina was there. She did a lot of this work. And then at Rice, obviously, Rebecca and her whole crew, and also some of the students at University of Texas at Austin. So I'll conclude here and let you all bombard with questions. Thank you very much.
Questions?
We always have a decrease in fluorescence in the location of the dysplasia or the lesion.
Mm-hmm.
You think it's because of what? It's because the fluorescence is much deeper, so light, excitation light, are actually going through the modified tissue, and then the fluorescence is underneath on the normal tissue, or you are not coupling light to that tissue. I mean, light is going out,
I'm actually going
reflecting
to
or something.
defer that question till after Rebecca's talk, because she's got students who will show you in vivid detail why we think that's happening. So I'm not answering that question yet because I don't want to steal her thunder.
Okay, a second question is, lasers and LEDs, they are not so different in price today. You can buy, let's say, a 440 laser for, like, I'm talking about a few milliwatts,
Mm-hmm.
for a few $100s. and a green 532 you can buy for $35 or something. I want to know the motivation of going to LEDs. I mean, this question is because I also in favor of going to LEDs, but I want to know why would be important for you to go to LEDs.
I think as a clinician, I can tell you two factors. One is another is the portability. They tend to be smaller, and so I could move it around easier. And then the second, I think, is because it makes the rest of the system a little bit more simple. You need less changes of filters if you have an LED. So that makes the design a little bit easier. And that's a clinician telling a world-renowned developer these issues, but so you can take that for what it's worth.
Yeah, but we all know that the fluorescent, in the case of the spectrum, not the imaging, LEDs are much, much poorer than the laser for the excitation and collection of the spectrum. Because the best we can do is 15 nanometers broad
Right.
for the excitation. If you want to use well the light, right? And also, we're having a hard time in coupling, but this I'm sure that will be solved very soon, is to couple 50% of the LED light in a fiber.
To the fiber, right.
Is already hard. So
I think also the future may be in LEDs. I mean, don't you think that they're developing very quickly? And
I think they should build the LEDs already coupled to fibers on the top of the fiber. They should build up. So. Yeah. Now, you mentioned a lot of different arguments and why going for optical, and but you did not mention how acceptable that would be. I mean, I can see that this is a good help for visualization. Do you think that medical community in general, pathologists and everything, will soon accept a result from a spectrum coming from a tissue instead of a histological exam?
no, but I think that will direct people to the right place, because currently, so before people are treated, before they get radiated, before they get surgery, they're going to need, they want to have that pathology, and that's not going to change in the next 10 years easily. But the problem right now is the patient, or at least in the United States, the patient goes to the dentist, they have a spot, and they either tell the dentist or the dentist tells them, and they say, well, what do we need to do about it? And your choices are you watch it or you refer to a specialist to get a biopsy done. And most people don't want to go that extra mile to get referred to a specialist, and then the specialist will have to do the biopsy, and the biopsy will be evaluated. So what happens is these people get treated with antibiotics or they get watched. So I think that's the value of the spectroscopy. If you could diagnose those that are dangerous without having to do that biopsy, then the people are going to follow through.
More questions? So this was an issue that we were discussing with Brian Wilson, if the community, the medical community, was really going to accept those results. And then if I asked him if he believed that we in the future would be able to replace biopsy or replace pathology, and he gave the same answer. Well, I think this is going to be impossible. But anyway, since you have been showing relevant evidence and also scientific base for this optical diagnosis, and then we are going to improve the efficiencies of detecting premalignant lesions. So as a clinician, what do you think we are going to do with those lesions?
That is the million-dollar question. Right now, we don't have good treatment for precancerous lesions. It's true. And I find that incredibly frustrating. There are treatments that are being evaluated that may be good in the future. One is photodynamic therapy, If we can get good agents that don't cause a lot of toxicity, because again, no one's going to die from a precancer. Two, there's something called chemoprevention, where you give agents, drugs that are non-toxic or relatively low toxicity to try to reverse some of these changes. And there's a very active research group in our center looking at different agents for chemoprevention. Have any of them worked yet? No. But can they work? Yes. And I think part of that's going to be determining which ones, looking at the molecular abnormalities associated with those precancerous lesions. Right now, we're just hitting everybody with the bomb. And what we need to do is figure out exactly what group they're in, what's causing them, what's the molecular abnormality, and target that molecular abnormality. I think that will come, but you're right. Right now, we don't have a good treatment. Nevertheless, if we can identify those patients who are at danger, that allows us to do what is the standard of care right now, which is very close observation, so that you can intervene when they get a cancer at an early stage, when it's very curable, versus they go away and they're never seen, and they have this massive cancer where the survival rate is low and the treatment is horrendous. So. Okay. Do you want to give them a break?